This is QD Clinic, brought to you by RoomNow.live. Interactive networking and streaming. That's the tagline for this meeting that starts on Friday. You can register online and watch it online. Our case today is called When to Stop Methotrexate. A 50-year-old gal who's had rheumatoid arthritis for 3 years has been on methotrexate for nearly 3 years. She comes in, she's doing well. This is a follow-up visit. She asks the question, how long am I going to be on this drug? I know we hear that all the time, often at the first visit, often when we first prescribe a medicine like methotrexate. And there the answer is unsatisfyingly easy, meaning I don't know, probably long term. I always tell my patients it's going to be a year. If I'm committing to methotrexate, it's likely to be a year. Talk to me when you've had a year or more of remission, and then we can talk about how long you'll be on this drug. And that's what this patient has done. She's had more than a year of remission. She wants to know, how long am I going to be on this drug? So some patients can go off therapy. The chance with rheumatoid arthritis, the chance of being on a drug-free remission is less than 10%, maybe 10% in some studies. The odds can go up in certain people, and maybe as much as 50%, meaning that when you stop the therapy, only 50% will recur or flare up again. So how do you know what to advise? I think you should, number one, know the ACR guidelines on this, which I believe are right, and that is if you have remission, you never stop therapy, because the odds are so much against long-term remission without therapy. The second rule is if you're in low disease activity, you can lower therapy but never go off of it. So if you're on a combination, you might be able to ratchet down to just one drug or ratchet both of them back to half dose. The idea is you can reduce but never go off with low disease activity as measured by a formal measure. So my rule is, again, show me a year of remission and then we can go off the medicine. Then your odds go up. But they don't go up a lot. They go up from 10% maybe to 20% if someone's in remission with 0, 0, 0 across the board if you're looking at the map of their CDI scores or their DAS scores or in my case, the GAS scores. Again, I think that patients would want this to happen as soon as possible. So you need to have some rules that will change the odds from 10% or less to 50% or more. And how do you change the odds? As I said, the longer they're in remission, the greater the chance they have of going off the therapy or taking less therapy, let's say. The odds go up if it's early disease. The odds go up if it's a seronegative rheumatoid patient, meaning they're both seronegative for RF and for CCP. The odds go up if they're not a smoker and they're not obese. And the odds go up if they lead a healthy lifestyle. Each of these will ratchet up the patient's odds of going into true drug-free, disease-free remission once they stop their methotrexate or other DMARD. We could be talking really about any DMARD in this situation, but methotrexate's a really good example. I discussed this with this patient. She's been in remission for 3 years. Her CDI scores for the last 6 visits have been 0, 1, 0, 0, 0, 2, 3, 1, 0. That's a little bit more than 3 years. She's done very good. She started out actually with a CDI score of 25, went down to 6 by her 2-month visit, and then after that she's been skating well. She's seronegative. She was offered the possibility. She thought about it. She said, I don't want to change right now. There's a lot going on in her life. So it's got to be right for the patient too. Do you want to chance that 50% risk of maybe having a recurrence? And I think that the idea that when it comes back, it'll come back angrier and be harder to control and you may not respond, I think that's overstated. I think that's based on old therapies that were largely insufficient compared to what we're currently using in our arsenal today. So tune in tomorrow for another tale from the clinic on QD Clinic.